Today is also a good question. Okay,
Yes.
so today, good morning, it is March 13th. And this is Senate Health and Welfare. We're picking up on S-151 and hearing some testimony that we could not fit in for the town break. And so probably the last testimony before we started having discussions around the room and trying to do a further markup on the bill. So I would start with Mary Kate. And there is
It's in front, unless you want one.
Oh, I won't stop it. Thank
Okay,
you.
anyone,
Do look
anyone,
good.
let them small. Thank you.
there's a new draft of
No,
151.
nobody wants one?
Is this, draft 2.1? That's the one I've been working.
The new draft 3.2.
Um,
And it's on the
Well done.
I have pictures.
That won't last long. I mean, the kids
So-
will, but.
so I just need to do something right now. So the room is now 2 over. So we have a quota in here of
So 2
16.
people need to leave,
So 2 people,
probably the last 2 people who came in.
or yeah,
So you're asking me to leave?
yeah,
right?
Yeah,
No, that's You wanna leave? Okay, thank you.
that's good. And it's a safety precaution, so nobody else gets more cold or somebody else's. Okay, so let's start with Mary Kate.
All right, good morning. For the record, my name is Mary Kate Bowman. I am Director of Vermont Public Policy for Bi-State Primary Care Association. We support Vermont's federally qualified health centers. We also support New Hampshire's, but I'm here obviously for the Vermont side. I'm going to speak to again, I'm working the previous draft that I had looked at, so if I'm off on my sections, I apologize. And I will also submit written testimony that is aligned with the most current, following this. The sections that I like to cover are section 7. This is the increasing primary care spending allocations. We are in support of this section, increasing the proportion of primary care spending in the state for commercial payers. Just because there's often confusion around how QHCs are paid. In some ways, they're very different from other primary care, but for commercial payers, they are paid the same way as other primary care providers. So anything that works and addresses commercial rates will also impact FQHCs. And I just call out that FQHCs are a third of primary care in the state. So anything that can support them, and this is a significant portion of primary care in our state. And in some cases, in some regions, they are the primary care provider. Example, in Rutland, they're 85% of primary care in your region. And that is, you want to make sure we support that primary care and the access to that primary and preventive care. This next section is 11. This gets at the Medicaid portion of primary care, and this is where FQHCs are paid differently from other primary care providers. The federal law sets an encounter rate, so it's the average cost per visit, is the rate that is supposed to be set for QHCs, and that there are other, I won't get into the methodology, but that's sort of the basis of it. This section 11, as it is written, would do nothing to increase Medicaid rates to FQHCs. And again, this is a third of primary care. We have suggested in House Healthcare that one way to increase Medicaid rates would be to set a state level minimum through an alternative payment methodology. You would still need to comply with the PPS rate, which is what we call the federally mandated minimum that is paid to health centers through the Medicaid program. But you could increase that for You can't pay them less than the PPS, but you can pay them more than the PPS. Feds say that's okay. So that we can offer language recommending what that state minimum could be. I've put forward some language on the outside, but I'm happy to share that with you here. And then the last section I would call out is section 12, the report from the Green Mountain Care Board to look at different rates paid to different providers and create more equity across providers. We support that. I would also, and this might be just a point for discussion, but one thing that I would also recommend looking at in that report is the reporting, the regulatory and quality reporting requirements. Primary care often bears the brunt of that burden. For example, at QHCs, we have the blueprint measures we have to report on, we have the PCMH. Technical reporting we have to meet. And then in addition to that, we have UDS reporting system, Unified Data System, that we are required to report annually to HRSA. And you can see all of that data on the HRSA website, but it's patient demographics, it's services, it's quality, it's finances, it's workforce. And then the other thing is they also have regular site visits, on-site visits from HRSA, which are fairly in-depth down to do the name tags meet certain requirements. So just thinking through what are the burdens that providers also have to carry in relation to their the funding that they receive for reimbursement. So those are my comments, and I will submit written comments that line up with the current draft, but I can also answer any questions one has.
Well, that's very helpful. Thank you. I know, knowing that whatever we do in the future is going to be very dependent on primary care.
Thank you.
But do get your clearance.
Well, thank you very much.
Who's next? Jill Olson? There she is. Good morning.
Good morning. How are you?
We're fine.
Thank you for allowing me to testify remotely. I am not in Vermont this week, so I'm sorry to not be with you in person. Because I had the advantage of going second, I was able to quickly glance through the new draft, and I can see that actually you've addressed my first three concerns, which I appreciate. So I'm Jill Olson. I'm testifying on behalf of Home Health and Hospice Agencies. And as a reminder, home health and hospice agencies provide 4 primary kinds of services. So we provide skilled home health, which is medical care at home. That's most often what we're talking about when we're talking about healthcare reform. We provide long-term care at home. We provide hospice care in all settings. And we provide maternal child health. So I just always like to remind everybody the different kinds of work that home health agencies do. So I am going to actually skip over my comments on sections 7, 8A, and 11, because it looks to me as though you've addressed all of them based on the testimony of previous witnesses. So thank you for that. I think we can now, I will confirm it, but I believe we can now support those sections with the changes that you've made. So I'm going to skip ahead then to 11A. I hope it's still 11A. I was working from draft 2.1. which is the intent language on the AHEAD model. And so we wanted to suggest that you add some intent language that's relevant to home health and hospice. One of our really big concerns about the AHEAD model is that it's entirely ignoring the parts of the system that are not hospitals or primary care. And many hospital discharges in particular are going to home health. So 16% of hospital discharges in Vermont go to home health. That's just a little bit less than how many go to skilled nursing facilities following discharge. So skilled home health is critical to hospitals' ability to move people through the system appropriately. And so our concern about the AHEAD model is that it's entirely ignoring all the other parts of the system. And CMMI, which is the arm that is doing all the innovation, is just not really addressing the fact that CMS, our primary payer, is really working against them. So they're cutting home health. CMS is cutting home health at a time when hospitals are going to need us even more. If they're going to succeed under global budgets, they can't have people in beds who don't need hospitalization anymore. They're really going to need to be able to get them discharged. And CMS is moving in the wrong direction on that. They're making it harder for home health agencies to operate. We're going to see closures of home health agencies all across the country. We've already seen one closure in Vermont this year. So it's really significant. And we've also got CMS moving, many beneficiaries are moving into these Part C or Medicare Advantage plans, some of which pay much, much less than traditional Medicare. And so those two things are having a huge impact on the ability of home health agencies to operate. And CMMI is just pretending it isn't happening, in my view. They're just not dealing with it. And so we've suggested some intent language, just asking that AHS in their work with CMS try to address this failure. I just want to be clear, AHS fully understands this problem and has raised this. They are also concerned with the lack of focus on other parts of the system. So that's one piece. Let me just pause there because I only have one other thing. So, and it's totally different.
Just a comment, if you look at page 17, number 5, when you get an opportunity, which does include intent, are some thoughts about long-term care. It's in yellow. See.
Well, home health is not mostly long-term care. Home health is mostly skilled. The term long-term care only covers a tiny portion of the work.
So the question is that, right, this came from Green Mountain Care Board's testimony, but your suggestion on making it home health, if there's some language you can offer, that would be helpful.
Yes, it looks like, so this I just want to say this keeps happening this session I've seen this in the House too, where I think people are attempting to include us, but they use that term long-term care. And it's really just a subset. In fact, it's not even our primary work. Our primary work is skilled home health at home, medical care at home. So I keep trying to educate everybody that we've got to think about it a little differently. So I will take a look at this and suggest some wording that would include us.
Okay, that would be helpful, and we'll educate the board that it's not long-term care, it's home health. Thank you.
Mm-hmm. Yep. Okay. My final comment is really, because this bill has a number of different sections, I've got some language that's looking for a home. And we're going to just keep working on this till we find a way to get this done. But it's a totally new topic, which is workplace violence in home health. I've talked to many of you about this individually. We have in Vermont a designated home health system. It's unique in the country. And what that means is that home health agencies have designated service areas, and they take referrals from all patients who are eligible for services. And so they don't have discretion about from whom to take a referral. In our designation rule, home health agencies are allowed to discharge individuals when there is a significant safety issue in the home. And there's actually an appeal process and for that when it happens. It's rare that we discharge for safety, but it happens. One of our recent examples was a family member of a patient got very angry with one of our nurses and chased her in his car down rural Vermont roads after the visit. And he only stopped after she got to a more populated area. So we're talking about like really serious, scary stuff out there. And unfortunately, under the designation rule, we are not allowed to deny a subsequent admission or even have discretion about whether or not to make a visit when someone's already been discharged because of safety. So even when we know there's an unsafe situation in the home, if the person gets readmitted to home health, there's no flexibility to not either accept the patient onto service or at least make decisions about whether or not to make a visit. I have to say, home health agencies are mostly erring on not sending individuals when if they really know there's a risk in the home, but our regulations sort of don't match. We have OSHA responsibilities to work to keep our workers safe, and we have designation responsibilities to serve all comers, and it's just not working. So what we're asking for is, I would say, a common sense adjustment to that process that would really just give us flexibility in those rare situations. So I don't know where else to suggest that this language go, but it's something that we are looking for a home for, and we'll keep doing that. And I think until we're able to provide a little more flexibility.
Jill, do we have that language on our webpage?
Yeah, it's in my memo.
Okay, that's helpful.
Yep.
I think a bill that we might have just acted on for the second read work, so.
Oh, okay.
I was just thinking that.
Yeah.
Which bill is that, Senator Lyons?
189.
Okay, I'll take a look at that. Okay. Yeah, no, the language is in my memo.
Okay, thank you. We'll have.
Great, thank
We'll
you.
try and have a conversation about that later.
I really appreciate it. That is all of my comments, so I will update my memo, but of course take questions if you have them.
All right, thank you.
There are 18 people in this room. What's the max for this room?
16. Okay, 2 more people need to. Sorry. All right. Okay, thank you. That's great, Jill. And
Thanks for
when you get
support.
here.
Yeah. Take care. Thank you.
Okay, so Heather Rice is here. Welcome.
Thank you. Kiki, do you see me up there or? Yeah. While that's coming up, I have this. Oh dear. I do have copies on paper in case you wanted to take some notes. But if you're okay. More than. Greetings, everybody. Thank you so much for having me here today. I first want to appreciate all the hard work that you all do for us, Vermonters, and everything to do with health. And I also appreciate the detail that you pay attention to things like items in this bill, particularly. My concern is specifically in opposition to the language around minor consent to preventative services and treatment for STIs. Who am I? I am Dr. Heather Rice. I am the clinic director at Wellspring Chiropractic Lifestyle Center. I'm a mother, and I also am on the board and a co-director of Health Choice Vermont, along with Dr. Sandy Ryder, who you've heard from, and Jennifer Stella, who you hear from to share a few thoughts at the end of today. So I represent, my own family. I represent the members of my practice. I have one of the larger wellness chiropractic family practices in the state. I've been in practice for over 40 years and here in Vermont since 1997.
And so I represent many of the concerned families in my practice, as well as a member and a board member of Health Choice Vermont, also over 5,000 members that are.
I went, oh,
Okay.
So my concern about the language in this bill is that it is going to be expanding what's already in statute and in a way that I think is concerning. So I wanted to shine a light on some of the details in the language. We currently have the statutes that do address treatment of venereal disease. And this language is being changed to broaden the definition to include the treatment and prevention of sexually transmitted infections. So if we just look at some definitions here, to make sure you get this. Okay, great. So disease, it's an abnormal condition negatively affecting structure or function. That means there's already a problem in the body. Infections are the presence of a microorganism, and it may not necessarily have any negative effect. So just because something is deemed an infection, it's not necessarily a problem. And some examples in regards to STIs, HPV, for example, never causes symptoms. It clears spontaneously without treatment in over 90% of the cases. Some other examples outside of STIs that you may be familiar with, strep throat. You can culture strep in the throat of many healthy people and still produce no pathology. Meningeal meningitis bacteria almost never develops into meningitis. Staph, Candida, other organisms that are found in healthy microbiomes, they produce no disease. Many people are exposed to influenza, even COVID virus, never get sick. This is a study from 1991, New England Journal of Medicine, that they actually did a study, almost 400 volunteers, where they literally were dripping viruses up their noses, including coronaviruses, and 1 in 4 never even got sick. So we know that infections don't necessarily equal disease. Prevention, this is a key piece. A lot of legislators, I think, are being led to believe that prevention just means providing information to minors. And actually, if we look at, does this merely mean counseling or best practices on safe sex or abstinence to prevent STI? You don't need to put that into a bill if that's what it really is. So it means more than that. And so it means it's including vaccines as preventative measures because they're given to healthy people and versus a treatment of a disease that's already affecting function. So just like any other pharmaceutical product, they come with risks, and therefore we have laws requiring parental informed consent because of that. The vaccines that are marketed right now as prevention for sexually transmitted infections right now would include up to 3 doses each of Hep B and HPV vaccines, and there are a slew of new vaccines in the pipeline as well. And some of these you've already been presented with: herpes vaccine, the gonorrhea vaccine. There's all kinds of papers being written on just what direction we should go in on the explosion of the sexually transmitted vaccines that are in development. And so, if we look at even the ones that are in development, the HPV vaccine, the Hep B vaccine was studied for 5 days to watch for any safety signals for 5 days before it was approved. And the post surveillance data is just being ignored of the injuries that have come from that, similar to the HPV vaccine. And so this is this language actually will violate federal law. And it directly contradicts the National Childhood Vaccine Information Act of 1986, which was put in place when vaccine companies were given immunity for liability to any injuries. This was a safeguard that was put into place. And it said that informed consent must come from a parent or guardian. Perhaps you have read the letter from Siri and Glinstead specifically pointing this out, and that a lawsuit is imminent if this bill goes forward the way that it is currently languaged. And so the question that I would have is, does this create a precarious position for Vermont healthcare providers who may be led to believe that this bill would allow them to actually violate a federal law, but then they may be vulnerable to medical malpractice because of violating that law? So it's confusing. In the District of Columbia, there was a minor consent law that was passed, and then there were lawsuits because of it. And so one of the plaintiffs in the case, and this was a case that was brought by Siri and Glinstead as well, one of the plaintiffs in the case submitted this drawing as testimony of what they had experienced while that law was enacted. And this was literally testimony that was accepted, and it did sway the decision. And one of the comments on this case were that it was because the laws placed contradictory duties on healthcare providers, which is exactly one of the concerns that I have. You know, we protect minors from marketing, from guns and tobacco companies. They can't get a tattoo until they're 18 years old without parental consent. And that's because their brains are still developing.
Excuse me, just, oh, would you mind just stepping out? It'll make people more comfortable. Thank you. Go ahead.
So their brains are still developing and they're not mature enough to make these kinds of decisions. And that's the same for medical decisions. In fact, I was just reading an article in the Heinsberg Record just from last week on, I wish I could remember her last name, Kara. She was writing about the difference between adolescents being processed as adults in court systems. And she really did very strongly quote how psychologists recognize that their brains are not developed enough to be able to make mature decisions, and therefore they should not be responsible for those decisions. So, you know, we don't let them drink or drive or smoke tobacco or get tattoos for a reason, because of how far their brains have been evolved. So this is true for complex medical decisions as well. Minor consent does not protect minors from coercion. As we saw in that last drawing, that child was feeling coerced, whether it was by their peers or whether in a situation where they're alone in a doctor's office. 15 years ago, I had an employee who told me that when she brought her 15-year-old daughter to their pediatrician, and the pediatrician requested that the daughter, or suggested the daughter would have some private time with the doctor. So the mother left the room, she went into the reception area, and then the daughter comes out later and she had been vaccinated with an HPV vaccine. And that was against there was no parental consent there. And the daughter, when she was asked, like, we talked about this, and she said, I was nervous, I just went along with what the doctor said. And so I think that's a classic example. When I shared this, my concerns about this bill with other members of my practice, just casually, one fellow says, oh yeah, I know a family that their daughter got the HPV vaccine and her health has never been the same after that. She's had trouble ever since. So minor consent does not protect minors from coercion, and it can increase the risk of iatrogenic injury. Kids do not know their medical history or how to recognize an adverse reaction. If parents don't know, then proper care could be delayed, and that's really important. Vaccine providers have no liability if the child dies or suffers with serious injuries directly caused by the administration of the vaccine. This would leave the parents, who didn't even consent to the vaccine, fully responsible for the treatment of their child's injuries. And when it comes to who's going to now cover the care for those injuries, well, it's going to be the parents. And, you know, yes, we do have a vaccine adverse events reporting system. And so, okay, but now a minor is going to have to navigate and file that report that adverse reaction. And then there's another compensation program. If you did get injured, how are you going to be compensated for that? Well, a minor is actually not allowed to petition for receiving compensation in the way it's set up right now. And the parents never knew there's important information that might have been needed to be documented and certain timelines that might have been needed to be met that could have expired. And now they are left perhaps with a lifelong injury with the parents having to foot that bill. Right now, there are 2 lawsuits, wrongful death suits from mothers of 10 and 14-year-old girls who died after receiving Gardasil. What if those children, what if the parents didn't even know and they're finding their child injured? We can't leave children to make these kinds of decisions. The Vermont Informed Consent Rule clearly states it means the consent given voluntarily by an individual with capacity on his or her own behalf or the role of an agent, guardian, surrogate, after being fully informed of the nature, benefits, risks, and consequences of the proposed healthcare, alternative healthcare, and no healthcare. So it's already right there. This is going to subvert parental rights. So, you know, when we look at this sacred bond of the parent and child, you know, these are quotes that were made again by lawmakers that were against minor consent bills in other states. We should never be alienating parents in situations like that. The state should not interfere with family members' medical decisions. So parents really need to be brought into this conversation, not barred from it. Parents should be involved because they love their children and want to protect them. Parents should also be involved because they're neglecting their children by not being involved. And so we need to have, if it's impossible in the home for that to happen, we need an independent advocate for that team and support for the parent as well. So it's a much bigger problem that needs to be addressed here. And since consent to sex is 16 years old in Vermont, there should be investigations for laws being broken, not just creating a normalization of this or an insinuation of condoning it by acknowledging that it's happening, but making sure the parents don't know. The solution is not simply to medicate a minor. And it was Dr. Marcia Angel, who is the editor of New England Journal of Medicine for over 20 years. Imagine the research that went across her desk and what she saw. And she said, you can never medicate your way out of a situation you behaved your way into. You'll just feel better as you get worse. Now, she was actually talking about the treatment of pharmaceuticals for chronic illness, but I think it actually applies here, that we have a problem with behavior and we're trying to address it simply by medicating. And I think that's the wrong direction to go, and it's dangerous and it's against the law. Our teens deserve much, much better. And so just to finish up, my daughter is here with me, and we had conversations about this, and I thought it would be very useful if she took a minute just to share what's her perspective at her age. So come right up here. It's my daughter, Alia.
Hello, thank you so much for your time. I've had many conversations with.
Please state your name. for the
Oh, yes,
record.
sorry. My name is Ollie McManaway. And I'm 21 years old, so this specific section pertaining to minor consent would no longer apply to me, but it was not very long ago that I would have been affected by this. And I can say that from my experience, as a minor, I was in no way ready to make an informed decision about a medical procedure for myself. When I've talked to my peers who are of a similar age, some of them have younger siblings, I have not encountered one that thinks that as minors we were ready to make informed decisions about medical procedures, and that our younger siblings are not in a state to be able to make those decisions either. We are people who we are no longer affected by this, and we don't have children of our own, but we are still very concerned about this minor consent. Another thing that I have some concern about is I understand that this is coming from a place where if a parent and child don't have a relationship where it's easy to talk about being sexually active and the risks involved in that. If that relationship is not there, it's highly unlikely that the child would have been fully informed of their medical history from the parents. And so in that situation, going in, even if they were to try and make an informed choice, they probably would simply just not know their medical history. And my last concern is that if a child was to be injured by some procedure, be it vaccine or whatever it was that they consented to, possibly under coercion or not, if they are unaware, if their parents are unaware and they do experience an injury, then they might not take the proper steps to document that properly. And then those people who are now potentially disabled or have some serious injuries are not going to be able to receive the compensation that they need, because that documentation, especially early on, would not have been there because the parents would not have known. And I'm very concerned that people who suffer disabilities from these things would then not be able to find the help that they need. Thank you for your time.
Thank you. Thank you both. Good way to spend a vacation. Okay, so let's move on. We're supposed to end this section at 9:45. We're gonna go a little bit over. So Sharon Hoagland is here. Welcome. Thank you.
For the record, my name is Sharon Kilgore. I'm a policy analyst with Vermont Rights Life Committee. The Vermont Right to Life Committee also has concerns about the section of S-151 that would allow children as young as 12 years old to consent to medical care for sexually transmitted infections without parental knowledge. Vermont Right to Life has a history of support for parental involvement laws because they benefit minors through improved medical care, as well as through protection from sexual assault and the dangers of secret abortions. As noted by the Vermont Department of Health, early sexual activity is associated. Would you like me to bring a?
I think I'm ready. I know you're afraid.
Thank you so much.
Happy birthday. I wonder who that could be from.
Excuse me, I'm sorry. Happy birthday. Thank you. I'm sorry, I really apologize. I didn't mean to interrupt like that. Thank you.
As noted by the Vermont Department of Health, early sexual activity is associated with an increased risk of unwanted pregnancy, sexually transmitted infections, and negative effects on social and psychological development. Young people lack the capacity to fully understand and appreciate the implications of engaging in sexual activity and are therefore incapable of giving truly informed consent. That is why Vermont's criminal sexual assault statute states that no person shall engage in a sexual act with a child who is under the age of 16, except where the persons are married to each other and the sexual act is consensual, or where the person is less than 19 years old, the child is at least 15 years old, and the sexual act is consensual. So sexual activity involving kids under 15 years old is always de facto sexual assault under Vermont law because no child under 15 can legally consent. While legal intervention is not always warranted, steps should be taken to evaluate whether a situation calls for it. We should all want to make sure kids are protected from exploitation as well as from their own immaturity. However, changes in laws and policies at both the federal and state levels, such as the change proposed in S-151, are making those protections for minors increasingly difficult. The tacit approval of early sexual activity by policymakers, activity that is literally criminal under Vermont law, makes it more important than ever that parents are informed so they can protect their children when the state will not. Example of some of these policies: allowing a child of any age to undergo an abortion without parental knowledge or consent, defining sexual assault in the Department of Children and Families Child Abuse and Neglect definitions in a way that differs significantly from the criminal definition, mandating that condoms be made available in public schools to both high school and middle school students, some of whom are as young as 12 years old and possibly younger. Carving out an exception to the mandatory reporting requirements, so no reports are required for middle school age children who are receiving those condoms and presumably engaging in sexual activity. Preventing parents from accessing medical records and insurance information for children once they turn the age of 12. And lowering standards for unprofessional conduct for providers of reproductive and gender-affirming care, enabling them to see minor patients in states where they are not licensed to practice without having any licensing ramifications here in Vermont. And recently a new proposal, S-220, to change the age above which libraries are prohibited from disclosing a child's records to a parent, lowering the age from 16 years old, again, to 12 years old. Laws that allow children to consent to certain healthcare treatments without parental knowledge also have the effect of creating obstacles for parents trying to access other important health information about their child, as I recently learned. Because some medical information can be legally kept from parents, parents are prevented from accessing any healthcare information online through a patient portal, for example, for a child ages 12 to 17. And a child who is under 18 cannot establish their own portal. My daughter and I both recently have undergone a screening echocardiogram after learning of some family history of heart issues. Neither of us received a follow-up phone call from our provider, but I was able to log into my health portal and read my own test results and see that my results were negative. I assumed, since I didn't hear from my healthcare provider, that my child's results were also negative. I could not, however, go online and get access to her test results. Recently, I had to contact the healthcare provider in regard to another issue, and I asked for confirmation of my child's test results that they were in fact negative, but they were not normal. And hopefully, this month's delay in receiving this information will not have negative consequences for her. Under S-151, will 12-year-olds seeking treatment to prevent STIs be informed that under Vermont law, they cannot consent to sexual activity? Do they have the capacity to read and understand the FDA patient information about a vaccine such as Gardasil, make an informed decision, and recognize and follow up on potential complications? And why would we ask or even encourage young kids to bear the burden of making adult decisions? This proposed section 1107 contained in S-151 would put Vermont even further down the path of lowering the age of consent and circumventing parents' involvement in the health and well-being of their minor children. And we believe the section should be struck from the bill. Thank you. I'd be happy to answer any questions if anyone. Thank you.
Jennifer Stella.
Good morning, everybody. I was wondering if I might be able to start my video. Wonderful.
We can't see you yet. We can see your books.
How's that?
There you go. Now we.
Hi
now we-
there.
Okay.
Wonderful to see you today. Thank you so morning. Good morning, and thank you so much for having me, Chair Lyons, Vice Chair Weeks, and members of the Senate Health and Welfare Committee. I would love to share my screen at some point soon. My name is Jennifer Stella, and I'm so grateful to all of you for the opportunity to be here and speak with you today in opposition to minor consent for preventative services, which appears in Section 4, I believe, currently in the latest draft of the bill. I see that the language has not changed. We're hoping to convince you otherwise this morning. I join you today as an individual with a background in science and marketing, education, and advocacy. I have a degree in microbiology and worked for many years in the field of infectious disease diagnostics and marketing. In fact, I helped design, promote, train, commercialize globally the amplification technologies that you may all be so familiar with now that you have been using for COVID testing. Those first tests that we launched onto the market were in fact amplified chlamydia and gonorrhea tests. Back then, direct-to-consumer advertising had actually just got started, and we were working very frantically on how to create messages in order to create the consumer demand for the products, which didn't even exist back then. And so I found myself designing ads for Cosmopolitan magazine and Teen Cosmo in order to promote the products to young folks so that they would be urged to go and get tested. I'm speaking to you today as a parent as well. In 2012, I became involved rather unwillingly politically on this issue, went out of necessity to protect my own children, who at the time were 6 and 8. You may have seen the pictures of them as adolescents on my screensaver. I never thought we'd still be here arguing about the basic parental right and human rights to informed consent for medical procedures here in 2024, but yet here we are again. But I do appreciate the opportunity, Chair Lyons, and I apologize for not being present in person for this testimony. I'm currently caring round the clock for my mother, as you can see, bags under my eyes. She was injured by the Johnson & Johnson COVID-19 vaccine 3 years ago in March of 2020, one and remain struggling in chronic pain and cannot walk. I will say that you are correct. This bill is indeed a lightning rod because of the state of vaccine policy in the US, and because if this bill is passed, it would be a clear end run around parents. It's really a slap in the face to millions of adult Americans who've either direct experience with vaccine injury or have serious, well-founded questions regarding the safety or the efficacy of vaccinations, particularly after our recent experience with Trump's COVID-19 warp speed exercise. I serve as co-director of Health Choice Vermont and co-leader of Children's Health Defense New England chapter. I serve as a volunteer in a volunteer capacity for these two organizations, and I am not compensated for my work. Both
We're not seeing your
organizations
slides.
and the many
We're not
members.
seeing your slides, Jennifer. We're not seeing your slides.
Oh, great. Okay, so let me see if I can try to figure out where they are. Can you see them now?
Yes.
Thank you, Heather.
Great. Okay, thank you, Heather.
Mhm.
I'll try to fast forward here. The language that we are concerned by.
And
It's making a slideshow.
Jennifer, so get to the slide that you're on, and then you've already been speaking for almost 10 minutes. So if you could continue with alacrity.
Thank you. With all due respect, I think 4 paragraphs. It must have been more like 2, but just to summarize, both organizations and the many thousands of our members are in strong opposition to your proposal to allow access to Vermont's children aged 12 and up for vaccination and medication expressly without parental consent. You've already heard much testimony about the shield from being held liable that pharmaceutical companies and pediatricians enjoy about the fact that this bill is in violation of federal law and subverts parental rights. And as I mentioned, it is a lightning rod, and I do highly recommend a public hearing and a long study period prior to moving further with this section, as there are many stakeholders who are not able to be present here today, including those who have just been asked to leave the room, as well as others who have sent in testimony, including many of the attorneys who have been referenced earlier. Supporters of this bill have openly stated that they want to increase vaccination rates in this age group. So the bill is clearly not about just providing information. And even if it were simply about providing information, I would say that in the 12 years I've worked on this issue, it's been abundantly clear that consumers are rarely given a true picture of the risks of the product. Ever since the first time the same medical trade organizations lobbying this bill tried to remove parental rights to object to even 1 dose of the 74 doses now on the list recommended by CDC for minors first school, the difficulty that we have had all along is really the provision of adequate information. I would like to ask you, if you have not done so already, it would be wonderful to hear from attorneys Siri Holland and Mac Rosenberg to explain their testimony, but I will go through really quickly general parent concerns, as you heard earlier by other witnesses. I won't harp on. However, the lack of liability and insufficient testing are really the foundation for consumer concerns around these products. Parents, being the lead consumer of the products, feel that they're not being given adequate risk and warning information. And we are seeing injuries being reported to the various official government systems, which are being downplayed and piling up, but are being ignored, or at least the perception is that they're being ignored. Parents are also concerned about the predatory direct marketing practices that are utilized in order to drive consumer demand, and our teenagers are extremely susceptible to those. The vaccine information statements, which are supposed to be provided by parents, I've taken just small excerpts from here so that you can see that each vaccine information statement, in this case for HPV vaccine, which is supposed to be given to the parent or guardian at the time of vaccination, refers to the injury compensation program. And it does say that the program was created to compensate people. The reality is that 9 out of 10 of these compensation applications are never compensated by the government. We actually have to find our own attorneys and fight against the Department of Justice, with the Secretary of Health and Human Services being the defendant in the case. It's extremely hard to get compensation. And one of the main questions is, how will the parent even be able to help the child or teen make that decision or go after compensation. If will they even get medical care, because the parent won't know. Also on every vaccine information statement, of course, it's talk to your healthcare provider if you've had an allergic reaction or if you've had any severe life-threatening allergies. Sadly, a child won't necessarily know about every component that they may be allergic to, or whether or not a family member has a history of allergic reaction to yeast protein or other components. When we talk about consumer protection, after many years of research, I can say in all honesty that I've been consistently appalled by the stunning lack of adequate safety data required for vaccine products in particular, far less than what we used to have to do to validate an actual diagnostic test. These vaccine products are licensed and approved for use in our children, despite evidence of harm that appears in the peer-reviewed published literature, as well as in the outcomes we see with our own eyes, which is abundant. And I'm willing to bet that a lot of the people that are with us today know at least somebody in their own family that has been injured. As consumers, though, just really a couple of things that I think people should know. The main question, what's in it? Just like every other product, what's in it? How is it tested? And what do other consumers say about the product? Will children be able to do this research by themselves? According to the CDC, there are substances in the vaccines that may be present in trace amounts. In these cases, the two products that would be open season for children to be eligible to accept without parental knowledge include hepatitis B and HPV vaccines, both of which are genetically modified vaccines and contain residues of the yeast protein used to carry out the engineering, as well as various forms of aluminum hydroxide, which we're told is perfectly safe. But the reality is that it is neurotoxic, and most teenagers will not even bother to look at what the labeling looks like. Now, inside that vaccine information statement, you can see that the CDC directs the reader to look to the package insert for the true final labeling for the product. The true package insert is never given to consumers or parents, but if one might take a look at the package insert for hepatitis B vaccine, for example, all package inserts are found on the FDA website. One might see that even in the package insert, the vaccine maker, in this case Merck, makes sure to tell the healthcare practitioner that they must inform the patient or guardian, patient or parent in case of a minor, of the potential benefits and risks. And then they also must question the recipient about their medical history, including any adverse reactions, which a child, in this case, if they had been vaccinated as a baby, may not be aware of. Prior to vaccination, they are to give this vaccine information statement, the excerpts of which you saw, and to tell the parent or guardian that to contact VAERS if there should be a reported adverse event. Now, I know that when we refer to VAERS data, it's constantly downplayed as data that is unreliable. However, it is the one system that consumers are directed to report to. So it's really disappointing that it's not taken seriously on the other end. Also in the packaging.
Jennifer, I'm going to ask that you've been speaking now to your slides for over 15 minutes, and I'm going to ask two things. One, it would be helpful to have your slides on a web page, and then if you could maybe summarize your testimony going forward and get to a wrap up. That would be very helpful. We have. Some of what you're presenting is information that we have heard from others, and we do appreciate that, but it would be helpful now so we can move on.
Okay, well, I might wrap up by saying, imagine, if you will, what kind of precedent this sets for all the choices the state might make on your behalf or behind your back without your consent. And if anything would have happened to your child or your grandchild, I wonder, we're not saying that the doctors are evil. They're just in many cases not as well informed as some parents who've already had vaccine injured children. Taking the parent out of the vaccine decision-making process and handing it over to doctors and government health officials who don't have legal responsibility for what happens is a violation of the human right of parents to exercise informed consent to medical risk-taking on behalf of minor children. And as others have already pointed out, this bill legally makes minor children adults for the purpose of denying parents and legal guardians access to their child's medical records, which also contain information that they may need about vaccines the child has been given. So I will skip over, this is compensation in terms of how many people have filed. There is evidence, of course, even recent evidence in March about how various pharmaceutical companies can spend millions of dollars promoting products in order to achieve their sales target goals, which are really vaccination rates. And I just wanted to comment that, unfortunately, the American Academy of Pediatrics is not an independent organization. In fact, in December of 2023, in mapping the grants, the $6 billion worth of grants that are distributed by pharma and its member companies, it's been revealed that American Academy of Pediatrics has actually received over $10 million from pharmaceutical companies over the years. And so we have a lot of questions that I'm happy to submit, but that have already been submitted by other witnesses in terms of how this will all work. 5 years ago, Colton Barrett was paralyzed from the neck down after an HPV vaccine. Imagine if his mother hadn't known that he was vaccinated. There are over 600 deaths associated with just the HPV vaccine alone. And we have a list of additional concerns that we'd love to have addressed. We respectfully request you to either withdraw the entire proposal. In addition, consider adding some provisions that will serve as safety stopgaps in case of promotion at clinics or schools, making sure that there is no coercion or bribery or incentives for the children. Also, we really would love to see parental consent, written informed consent, and true informed consent, including failure to provide, be written into the informed consent law. As a parent of children who are now adults but went through the adolescent period, I do want to say that I do concur that it is really a tender time where they are seeking independence and seeking privacy. And so we don't argue about the need for the children's privacy or their desire for it. However, parents are in the best possible position to make these decisions. And I believe that Vermont would be making a grave mistake that you won't be able to walk back from should a child be injured and a parent not be informed of these decisions. So I ask you again to please withdraw the minor consent language. Behind every young child who believes in himself is first a parent who believed in that child. And while there may be some children at risk who are homeless, the vast majority of children would benefit from caring parents, helping them navigate these complex medical decisions in which there are risks that are known and unknown. And the legislative history does show that when mandatory vaccination laws were put into place in 1979, the comment was, of course, parents will always have that choice. We believe that this is just an end run around the parents, and we hope that you will reconsider. Thank you very much.
Thank you, Jennifer, and thanks for all the information. Again, if you can send your slides in, that would be helpful.
I'd be happy to do so. Thank you so much for the opportunity to present to you today, Chair Lyons. And
Very much. Good. Okay. So we're gonna turn to looking at the latest draft of S-151. I'm gonna suggest that we do that at 5 after, take a short break, and then Jen will go on to the draft 3.2. So we're gonna go off